So welcome everybody to this session about the sinus reducer. So I am Martine Schiller. I am an interventional cardiologist from France, and it's my pleasure to co-moderate this session with Stéphane Verhey from Belgium. So during this session, as you can see, we will have a lot of expert team. And as you can see their picture, and they're also on stage. So there is an expert from France, from Germany, from UK. So it's a great team. And the objective of this session, we will, during this 1 hour, we will try to share with you how this sinus reducer is working, what is the mechanism, to share also the data about refractory angina and also another disease, and but it's very important, some tips and tricks in order to that you can use it and you can understand how to use it in your daily practice. So for the first part of this session, I give the micro to Stéphane.
Thank you, Martine. It's a pleasure to be here, and I would like to welcome everyone and thank, I used to say Neovasc, but I have to say Shockwave now to support the session. It feels a bit unusual, but anyway, so we're glad you're here, and the plan is really to, I'm going to be your spokesperson, so really if you have questions, don't hesitate. You can submit them directly, and we will be able to read them and address them to you. We will entertain this discussion with the panel. So please don't hesitate and ask whatever you want to ask. We will address them. So we will, as Martine said, we will have the live case, and then we will have discussion. And then we really want to engage you on this novel therapy. And I'm sure that for those who are not familiar with the reducer, but still have a lot of patients with refractory angina, so that you know at the end of the session that there is a very good alternative to treat these patients. Having said that, I want to introduce a poll, and then we want to do another one at the end of the session. And so the first question, and please address that question, we will have an immediate answer. The question is, how do you currently treat your patients with refractory angina? And A is going to be medical treatment, and B is going to be the coronary sinus reducer. For us to have an idea how many people actually are familiar with the coronary sinus reducer in treating patients with refractory angina. So please feel free to address that.
So it will always take time to have the answer, but I think you have a great participation, and we can see that it's equal. Actually, in your cath lab, it's equal to when you have a patient with refractory angina. Some of you use it's better now. Some of you use more medical treatment, and less of you use a sinus reducer. So in order to be very in practice daily, we choose to present you a case, a real case, and I asked Thomas Cuisset, which is very undisciplinary, to present the patient.
Yeah, thank you, Martine, Stéphane, and thanks for inviting me in this session. So the case we'd like to share with you today, as you will see, is really a typical case of refractory angina. So it's a pretty young patient, 57 years old, with significant risk factors, and he had 7 years ago CABG with Lima and the LAD, but unfortunately he had also saphenous venous graft on the right and on the circ, but which were previously occluded based on prior angio. He was admitted in our institution for refractory angina and significant one, class 3, with also inferolateral ischemia on the non-invasive testing. So he had good preserved ejection fraction, and he only had as anti-ischemic drugs 5 milligrams of bisoprolol. So accordingly, he was admitted in our institution for invasive coronary angiography. So on the angio, of course, this patient had a critical disease of the native system, as you can see, with occlusion of the LAD, almost occlusion of the circ system, and also complex CTO of the right coronary artery, which was obviously the reason for the CABG 7 years ago. So basically, has only the remaining lima to the LAD that you can see here, which is patent without critical distal disease. So at this stage, we consider that, of course, can be discussed, especially if we bring with us some CTO expert, but we consider that there was no real and reasonable option for revascularization. So first step was just to optimize the anti-ischemic drugs by increasing the dose of bisoprolol and adding long-acting nitrates as well as nicorandil. But unfortunately, this patient had no improvement during the follow-up, so he came back to us to ask whether we could do something more than just new medication. And we had an internal discussion, but honestly speaking, we had a quite short discussion according to the anatomy of the patient, whether we should try a very complex CTO attempt or just a sinus reduction for this patient. And after this short discussion that we had, this patient was considered as a good indication for coronary sinus reduction.
Thank you, Thomas. So before we discuss about this patient, I think it's important for everybody to know how this new device works. And it's my pleasure to introduce Tommaso, who presents you how this sinus reducer decrease the angina pectoris.
Thank you very much. So this is going to be 4 packed slides and 8 packed minutes full of information about physiology of ischemia and angina and mechanism of reduction through the reducer. So we all agree that there is more than just epicardial stenosis to the cause of ischemia. There are structural anomalies in the epicardial bed, which we call atherosclerosis and epicardial stenosis. Then there are structural anomalies in the microvascular circulation due to remodeling, rarefaction of capillaries, fibrosis, substitution, and so on. And then there is vasomotor functions in the epicardial coronaries and in the microvascular circulation that is a failure to adjust, that is a failure in the autoregulation phenomena at rest or during hyperemia. This is just to say that there is several components to ischemia. Now, what happens in healthy people when they are under stress, whether it's physical or mental, there is a selective beta adrenergic activation, which works the other way as in the rest of the body, that causes a vasodilation selectively at the endocardial layer of the myocardium and a relative constriction of the subepicardial microcirculation, and that balances or rebalances the coronary circulation, coronary perfusion towards the endocardium, which otherwise will become ischemic. In patients with coronary artery disease or microvascular dysfunction alone, there is a contractile dysfunction, a relative increase in left ventricular end diastolic pressure, a relative increase in wall tension through the myocardium, a rise in prearterial pressure in the non-ischemic segments, and therefore a blood redistribution, a blood flow redistribution from the subendocardium to the subepicardium. And this is the reason why chronic coronary syndrome patients are more prone to subendocardial ischemia than subepicardial ischemia. So this is the rationale for the reduction, actually, for the sinus reducer. What happens if you increase venous pressure through a reducer or through a balloon or whatever, that redistributes the blood flow more or less from the epicardium to the endocardium. That increases the total blood volume in the myocardium. That leads, again, to a redistribution of flow towards the endocardium. And what I think is even more important than that, this increase in the total blood volume in the myocardium reduces blood viscosity, which is not a fixed parameter intrinsic to blood, but a variable parameter dependent on shear rate through the circulation. So this is an example. This is a study we did in Mainz. It's not to do directly with the reducer. We did a crossover randomized sham-controlled study where we occluded temporarily the coronary sinus with a balloon, with a Swan-Ganz balloon. We measured coronary resistances in the sham condition and under occlusion of the coronary sinus. And this is the coronary resistances at rest and under hyperemia. So there is a significant drop. And we found it at the beginning quite controversial, hard to explain, because occlusion of a vessel causes a decrease in resistances, but it actually does make sense if you followed me on the previous slide. So the reason, the mechanism to occlude or reduce the sinus over a prolonged time is either through surgery or through implantation of the sinus reducer. This is the coronary sinus. You will see it in the case that is going to be described later. This is the sinus reducer ex vivo, mounted on a balloon. In the next video, you will see the coronary sinus reducer implanted with a little bit of overexpansion, as it should be in the coronary sinus. This is a metallic mesh made of stainless steel. It's a one-size-fits-all, and it's adjusted in size with the balloon implantation at different atmospheres. So this is one slide of results. There is a randomized sham-controlled trial, and I want to emphasize it, sham-controlled trial, where angina was the primary endpoint, and it showed not only significant, but a massive difference between sham-treated or control patients and patients treated with the coronary sinus reducer. There is a plethora of registries showing exactly the same thing and confirming this evidence. With this, I'm finished, and there was a quick run through coronary physiology and ischemia.
Thank you, Tommaso. So you can take place, and I think you will have a lot of questions about that. So in order to begin, so do not hesitate to use the application for posing question, or you can also use a micro. So the first question that I think is important is to Stefan. And what is the prevalence of the refractory angina in your daily practice, and also how to detect them?
Thank you, Martin. It's an important question, and it's also a difficult question. But if you look into the literature, I think that we are looking at numbers of, especially like post-CABG and post-PCI, numbers of still patients having 20 to 40% of these patients still have refractory angina. So I think we all think that we do a good job, but we're definitely underestimating the prevalence of refractory angina post-PCI and post-CABG. So that's one. I think if you look at the numbers of patients undergoing cardiac catheterization, again, when you look at the numbers in the literature, there's about 5 to 15% of these patients with diagnostic angiograms who have refractory angina. So that's a lot. To me, that's a high number for those patients undergoing diagnostic catheterization. And then when you look at the numbers in the US, how many new patients with refractory angina per year, then we're talking about 50 to 100,000 patients a year. And for Europe, these numbers are somewhat less, but still in the range of about 30 to 50,000. So all in all, these numbers are high. There's a lot of patients with refractory angina. And then, of course, when you talk to colleagues and physicians, they say, well, especially when we introduced the technology with Professor Banai, it was, where do you find these patients? I don't have these patients, but you have to look for these patients, and they are out there. They are all in your practice. It's just that you have to keep an eye on them, and you have to find them. And finding them means you have to do investigations. And so also as part of the COSIRA trial, and all these patients had to have angina, but not only angina, they had to have reversible ischemia. So you try to find them in the clinic. You ask colleagues. There is a heart failure clinic. So everyone involved, referring physicians, you just try to say, where are your patients? And if you have these tests like spectalium or bike test or treadmill, a PET scan, whatever that contributes to see reversible ischemia and angina, I think that that is easy to find them. It's just a matter of thinking of them.
Thank you so much.
In the meantime, I see there's a lot of questions popping up, but while we're doing this, I'm going to submit a question to Julien. Julien, what is the impact of refractory angina, you think?
The impact of refractory angina, I think it's mainly quality of life that might impact the refractory angina. And to say and to support what you are saying, it's at the first time I had the same difficulty to find patients, but then by talking to the cardiologist, doing outpatient clinic and so on, you will find a lot of patients which are not dedicated at all to the cath lab because they stayed with this image that you have such an advanced coronary artery disease, or you don't have it, you have INOCA, and you have nothing else to do, so keep it there and won't have any cath lab anymore. And so this is why we lose them. And they stay under medical therapy and so on, and they are quite limited in their activity, or they have symptoms but they don't express it to us, interventional cardiologists, but more to their cardiologist. So it's really a work to go to see the cardiologist of your hospital and to tell them that you have this solution. And when you start a program, it starts well because you have a net effect, which is quite important. And then it goes by itself that other cardiologists will send you these patients.
Thank you, Julien. There is a couple of questions on coronary physiology based on Tommaso's talk. So I want to submit that question to Tommaso. What is the idea of putting this reducer in the coronary sinus? Does it, and again, related to the resistance, does it increase or decrease? You touched upon this. And then the second question is, what could be also the role of coronary physiology in finding these optimal patients like CFR and IMR?
So the both important questions. So to the first one, what happens with coronary physiology at the time that the reducer is implanted? It's essentially the same thing that happens in your garden when you water your plants. If you close the hose or you reduce the size of the hole in your hose, you won't reduce the flow of water going through the hose, but you will increase the pressure in the hose so that you can water the plants away from yourself without getting your feet wet. So essentially, you reset with implanting the reducer. You reset the flow at exactly the same level, but a higher pressure. So the consequence of that is that the intravascular pressure in the myocardium increases to adjust to this increase or to maintain the flow through the device. The increase in pressure in the venous system and in the myocardium increases blood volume in the myocardium, which decreases microvascular resistances and decreases viscosity, or because it decreases viscosity. So this is essentially the mechanism as far as I understand it. Probably there is a plethora of other mechanisms. Now, with regards to the question of my colleague, actually, whether we should use FFR or IMR for selecting the patients that should be treated with this device, the answer is you have to make sure that those patients have angina because they have ischemia. And don't take it polemically, but all the methods that we have historically for assessing angina, they are focused on epicardial disease. So you can do CT, this is epicardial disease. You can do stress echocardiography, and this is regional wall motion abnormalities, so it's epicardial disease. You can do SPECT, you can do scintigraphy, it's all epicardial disease. So if the patient has angina and none of those tests is positive, then a good way to study his ischemia and his angina is to assess the microvascular function. And I can tell you from my own experience, this device works incredibly well for microvascular angina patients.
Okay, so there is a lot of question for the procedure, so it will be treated just after. And a question for Jonathan, which are the percentage of patients who are not responder to sinus reducer, non-responder at all? It doesn't. You implant a sinus reducer and you have no improvement of the angina.
Well, there is a significant proportion who don't respond, which we learnt during the COSIRA study. But I think the positive message is that 80% of people did respond. I think we became very adept at recognizing the patients who were going to respond, and with the concentration on left-sided disease. So we know that patients with isolated right coronary territory ischemia don't seem to respond in the same way, and this relates to the venous drainage of the heart. So I think if you were going to treat patients with right coronary artery disease, then I think there's a higher chance of a non-response. I don't think it's a completely, they're always complete non-responders. But there is also a variation in the degree of venous collateralization, which I think influences the way that left-sided disease patients respond. And I think there's been some very interesting work looking at measurement of coronary sinus pressure, so with a balloon up and measuring distal pressure. And if there is no change in the pressure, so in other words, that if you were to put a sinus reducer in position, that you wouldn't have any upstream influence on the endoepicardial pressure gradient. Those are the patients who don't respond. We haven't introduced that as routine to the procedure, but I think it may be one tool to use to filter out non-responders. I think people who don't have any ischemia on the left side, I think are less likely to respond. So I think corroborative evidence, whether it's PET scans or MRI or stress echo, that if you don't have that evidence of ischemia in the left-sided territory, then they're unlikely to respond.
Thank you, Jonathan. I have a question for Thomas. Thomas, you, in your case that you're going to present, you touched upon the possibility of doing a CTO, a complex CTO procedure. So you can see my question coming here is, what kind of strategy do you choose here? There's a question from the audience, and that's why I'm asking it. What would be your first step treatment? I mean, CTO, and I don't know how many CTO experts there are in the room here, and CTO hasn't really proven something. So here my question is it CTO or is it reducer, and how do you see the future?
No, I think it's an interesting question, but it was a little bit provocative statement, which works because we have questions from the room. But I will say that this patient, he has CTO of the circ, of the right, so it's really diffuse disease, and I think patient with prior cabbage and multiple PCI is probably one of the best candidates, at least in my practice. Well, I will say that if you have a CTO with high probability of success, which I think I will base my decision on the complexity of the CTO. I mean, if you have a short CTO, non-calcified, with very high probability of success, probably the CTO attempt makes sense because still we have evidence at least on the symptom of the patient. But my point was really to balance what we see sometimes. I mean, the very complex and multiple CTO attempt, while we have another option. So what I wanted to reflect on is now we have a new option, a new treatment available for patients with complex coronary artery disease. And where should we integrate this new option among the available ones, including the CTO procedures? So I think we need to reflect on that. And I don't know if one day we could imagine randomized patient with CTO failure between new attempts or coronary sinus reduction. Maybe, we'll see.
New trial. So Thomas, could you show us your case?
Hello everybody, welcome to La Timone Hospital in Marseille. My name is Thomas Cuisset and I'm very happy to work today with my partner Pierre de Haro. And we will treat with the reducer device the patient you've just seen, which is a typical patient with a refractory angina. So as we discussed, the procedure will start with the echo-guided puncture of the jugular vein. So we check on the angio that we are on a good spot. So next step is to put the 9 French sheet in the jugular vein. Yeah, so Pierre, indeed, the setup of the room is very important. And just after the puncture, there is 2 things to do. The first is to go LAO 30, which is the projection for the implantation of the device, and also to have the table like this, as we will work for a subclavian TAVI, for example. We start with multipurpose catheter and the G-wire. So we see we are in the right atrium, and we try to go into the coronary sinus, which usually goes up.
Okay.
And what we will do first, we will do an injection. So I have no backflow here, so I'm probably against the wall. So just to be sure, we start with just the angio of the coronary sinus.
Okay.
And so the next step, we will ask Sébastien, our technician, just to do kind of QCA as we do for coronaries. So Pierre, following the angio and the measurement made, we can see that we are between 6 and 8. So at this stage, it's let's say the validation based on the anatomy. So 2 things to do is to open, let's say the kit, because we know we will proceed with the procedure, and also to give some heparin at the, let's say, PCI dosage, which is 70 units per kilogram.
Perfect.
So Pierre, we've seen that the anatomy is somehow challenging. We try first with the G35 wire, but we didn't have enough support, so we decided to try a Terumo stiff. And we can see that now we have a good distal position. And my advice will be always to have a kind of reference on the other screen and to exactly try to define the landing zone during the implantation. So Pierre, we say that the anatomy of coronary sinus is fine for the device implantation. We had to struggle a little bit to put let's say, the good wire according to the patient anatomy. So next step is to open the kit of the reducer, which come with first 9 French guiding and 9 French valve connector here. And on the other hand, we have the reducer device that we should just remove from the first plastic tube. Then you just remove the metallic still. And then there is still a small plastic tube for protection that you have to pull and push, but very gently to be sure not to mobilize the reducer device, which is just here. Okay. And the next important technical step is when we will do the inflation of the reducer device, we have to put very small proportion of contrast, because we know that the profile of the balloon sometimes it's quite challenging to be fully deflated. So we have really, usually for PCI we do 1/3, 2/3, but in this case it's really 15-20% of contrast only. The next step will be just to a little bit pre-shape the 9 French sheet. And what we will do, what we used to do also for coronaries, is just to do mother and child by as you can see that Pierre will put the initial multipurpose 5 French into the 9 French, and it will make, let's say, the profile of the whole system a little bit easier to navigate in the right atrium and in the coronary sinus. Good. Also, Pierre, I think important point is also to keep always the same projection, because we can see that now we have the reference, so we can say that the distal part of the landing zones should be just at the right part of the spine. Yeah. And in this case, we know exactly where we are. Of course, we will be able to inject contrast also in the guiding, but it's a good starting point to have that in mind.
So you don't want to be too close to the ostium, and you want to be just before the bifurcation. That's
yes, exactly, Pierre. So we will just, let's say, put the distal tip of the guiding just a little bit distal to the pre-specified landing zone that we decide during the first injection. So we go with the mother and child system. And we have to go very gently in the right atrium. and to avoid what we call a belly sign, which is that the curve in the area is becoming too large because we know that it's not appropriate for device navigation. So Pierre will really have to manage the wire to be sure that we don't have too much belly sign. We go very gently. The patient is fine, is obviously very stable. So first we go to the landing zone, as you can see, with the multi-purpose, which is, I think now we are in a good position. So next I will do fixed point on the multi-purpose, and we will very gently advance the 9 French guiding. So again, we can see that we have a belly sign, which is a little bit too much at this stage. Yeah, we have a nice jump, Pierre, because we really seen that the guiding enter the coronary sinus. So now it will be easier exactly to reach the position that we define. I think now it's a good position, if you agree, Pierre.
Perfect.
And we can just remove the multi-purpose and keep the wire in place.
Yes.
And the next will be to put the reducer on the wire. We'll go very gently with the navigation. So again and again. So we can see you have
three markers.
Yeah, we have 3 markers. And so the idea will put the distal one just at the tip of the guiding without going outside the guiding. So we go gently, and again we try to avoid to have the famous belly sign with the huge curve in the lateral part of the right atrium. And I go really, really gently up to the tip of the guiding without going outside. And what we can do, Pierre, just to check that the device is nicely in place between the marker 2 and 3. And what we're gonna do next is just to have fixed point on the register and just to remove the guiding between the first and the second marker, just to free the space for the reducer device to be able to be deployed. So as we say, Pierre, here, what I will do is to have a fixed point on the reducer device, which is going always a little bit forward, and just to remove the guiding between the marker 1 and 2, and then the reducer is free in this case.
Yeah, the feeling is that despite the challenging anatomy, it's everything is going smoothly and it's very stable.
Yeah, I think the profile of the device is good, as long as probably we select the good wire to have enough support for the navigation in the right atrium and also in the coronary sinus. So Pierre, what we did now is just you just put 1 bar inflation just to stabilize the device. But if you look at the landmark that we had, I think we are probably a little bit too distal and probably beyond the bifurcation. So I think we can come back very gently. I think here it's good. And what we can do, we have the lateral port here, and we can do a contrast injection to see exactly where we are. So be very...
You can aspirate.
Yeah, we have to aspirate. We have good backflow. Of course, we are in the venous system, but we have to be sure that we have no air embolism. So I think we are in the proper position. I think, Pierre, exactly where we want to be. It's distal enough from the ostium.
Mm-hmm.
Of course, So Pierre, we can say that we are in a good position. So what we can do next is to go up to 3 atmosphere. And the idea is to keep the device inflated for 30 seconds.
Okay, we are at 3 atmosphere now.
So that's good. We will just make a graphy to see a little bit the shape of the device. And I think it's fine. And what we will do during the inflation, we will just give a little bit more contrast, that to be sure that the device is well impacted in the wall and there is no risk of embolization. I think it's good. It's good example here, huh, Pierre. And what we can see that we have the feeling that the device is already a little bit bigger than the coronary sinus, which is a good way to lower the risk of embolization. So as we say, Pierre, we will start by empty completely the deflator here. And when it's done, of course, you have more space to have optimal negative pressure.
It's still coming back a little bit.
But it's fine. I think it's just what we had. And we will do it, as we said many times, and really to wait, because I think the risk, as we experience for coronaries, if you try to remove the balloon too early, we might have some mobilization of the device. Okay, so Pierre, now the balloon is fully deflated, so we really take time. We'll just do a short contrast injection. And it's fine. We see that the device is nicely opposed to the wall with most probably very, very low risk of embolization. So as we discussed, Pierre, we are really now in the middle part of the device. And next step, you will keep the wire, and I will gently pull on the balloon and also on the guiding, because we don't want the guiding to cross the central part of the device. So I will go, as you can see, very, very gently.
Okay.
And now the balloon is back in the guiding, and we have still the wire in place. And the next step will be just to do a last injection. So we inject. So I think position of the device, Pierre, is good. And it's just really just proximal to the bifurcation, and we don't have a distal perforation. So I think it's a good result in this case.
Yeah. And now, Thomas, we just completed the case. What is next for the patient? Is going to go home today or tomorrow? Do you need an echo? And which treatment do you need for your patient?
Usually, it can be ambulatory patient. And this patient arrived yesterday because we wanted to discuss a bit and to explain. But usually, the patient will be discharged just this afternoon. The follow-up will be planned between 6 and 8 weeks, and we will probably repeat both the clinical assessment, but also maybe the non-invasive testing. And in terms of antithrombotic strategy, current recommendation is to give DAPT for 3 months after the reducer implantation. But most of these patients with very complex coronary artery disease, they already have aspirin and clopidogrel on board, so there is no additional antithrombotic strategy.
So, congratulations, Thomas. And before question, I think it's important to summarize the key point of the procedure in order that everybody understand very well the tip and tricks of this procedure. So, Tommaso, could you?
And now I'm challenged with my technical skills here. So, I'm asked to give can I have the magic screen? So I'm asked to give a best of, or actually a worst of, where are the troubles? Where can the troubles come from? And my very first recommendation would be to look in YouTube for this name. If you want to engage him, is sitting behind my back here on the second row, and he has at least 3 cases registered on YouTube, and those are really good. So the first thing that you have to do is you have to find the coronary sinus, and this may be challenging, of course, like any other anatomic structure in the body. One thing that helps sometimes is to remember the anatomy, and the coronary sinus, the ostium, is here. It's exactly in the middle between the inferior vena cava and the right ventricle. So you may try and probe both of them and see, and your goal is in the middle. How do you do it? The best way, or the first scenario, is that you try and do it with a multipurpose, as Thomas did. So this would be something like this. And the trick is, don't go with the wire, just go with the multipurpose straight ahead and just rotate it and try to manage the coronary sinus. It is safer than going with a wire, indeed. I wouldn't believe it, but it is indeed safer. If that doesn't work, then you have to try another way, or at least two other ways. One is with an Amplatzer catheter that is a little bit more maneuverable, maybe a larger Amplatzer catheter, so 1 or 2. Or the other option is to go with a coronary sinus sheath. There are at least 2 that gives you a little bit of a curve, and then try again with another catheter. So once you're in, then you have to obtain a little bit of backup. And the backup depends on the anatomy of the sinus. I'm fast. I'm almost finished. There are people with a coronary sinus that goes like this, more or less horizontal. There are people with a coronary sinus that goes a little bit more vertical, which is more challenging. This is the ostium. And my own take is better to go with the multipurpose and stay with the multipurpose catheter into the sinus. That gives you a little bit more backup as compared to a wire. The next thing that you want to do is implant the reducer. This is again the sinus. You would like to implant it over a valve because the valve occludes basically the sinus, at least in part, and holds the reducer in place. And my own trick is to go with successive inflations instead of going directly to 4, 5, 6 atmospheres. Start with 2 or 3 and then go forward until you reach a little bit of over expansion, which is the goal up to 20%. The last thing and last challenge before you go home happy is to retrieve the coronary sinus reducer. And as we've seen in the case, of course, you have to take the balloon, the deflated balloon, here, now deflated balloon through the stenosis. To do this, you have to have your sheath forward, push in very gently on the neck of the reducer and avoid that it displaces or gets somehow compressed. It sounds complicated. It is indeed very easy. Thank you.
Thank you, Tommaso. That was a very nice overview. And I also would like to thank Thomas for showing this educational case with a lot of teaching points. Now, the audience has a lot of questions, and I want to submit them to Thomas with regards to what about perforations? What about if you have a diagnostic angiogram before you do the procedure, you end up with a dissection, what do you do? That's one. And what do you do when you have a dissection after the implantations? How do you manage that?
Yes, thank you, Stefan. So fortunately, maybe I don't have yet a larger experience large enough, but I did not have this kind of complication. But I discuss, and I think I will really advise you to do so, is to discuss with your EP colleagues, which are, for me, just in the room next door, to ask what to do. And they say that in most of the case, it will heal. And of course, we should check that there is no pericardial effusion. But in most of the case, even if you have small image of dissection at the end, I think you should just look after the patient, but not to do specific intervention in this case.
Yeah, I would agree. I mean, I had once the experience of having a dissection, a huge dissection with a diagnostic catheter. And you just leave it, and you bring the patient back in after 3 months. It's completely healed, and you proceed with the procedure and implant the reducer. So it's not really an issue. There's a lot of questions, and I want to ask Jonathan to address that. And that's all about the coronary sinus. Apparently, there's a lot of EP guys here because they think of the coronary sinus as being the place to put leads in there. For whatever HFpEF, HFrEF, and what if you do if you have a patient with refractory angina and already has a lead, and what about the patient who has a lead and has refractory angina? What do you do to them?
Well, I think we naturally think they're incompatible, but I think it's not the case. I mean, the coronary sinus is a very distensible structure. And I think if you've got a reducer in place, for example, and you then need to consider a patient for pacing, you can actually dilate the coronary sinus reducer fairly easily. But it is possible, and I think there have been a number of cases done where you can implant a reducer alongside a lead, and you rely on the distensibility of the device, of the sinus, that it will conform in the same way, and you will put the lead to the side. I don't think it's something to be recommended, but it's not impossible.
What about the access, Martin, from the groin? Is there a possibility? We've seen the case by Thomas that we do the access from the jugular vein, but do we have alternative approaches?
Some teams use the access from femoral, but however, the curve is not so good. So, as Thomas explained a lot during the case, he said that we need to have a very small curve and very smooth curve in order to have the strands to implant the sinus reducer. So, if you go by the femoral approach, the curve will not be the same, and sometimes it will be difficult to maintain the guiding catheter and to push the sinus because you have not the good curve. So it's possible, everything is possible, but it's better to go by a jugular approach.
And there's one question I want to submit again to Jonathan, because you talked about the occlusion, the coronary sinus occlusion with the balloon. So the question is, how long do you do that? And what is your strategy? How do you measure? And what is the expectance of pressure changes?
I'm probably not the expert to ask on this. Probably maybe Ranil, who's in the audience. Maybe, I don't know if there's a microphone. You could speak about your experience, Ranil.
In terms of the inflation pressure that you choose for the reducer, often that's guided by the contrast injection to make sure that the sinus is a little oversized in relation to the diameter of the sinus. But was that the question?
The question is, how long do you occlude the coronary sinus to measure the pressure changes that you see?
Ah, right, okay. So we've only recently started to measure coronary sinus wedge pressures as a routine. Normally we measure it continuously, but during the inflation, probably for at least a minimum of 30 seconds before the pressure tracing normalizes.
And what kind of pressure drop do you anticipate? Or maybe Tommaso, you have experience with this?
No, Tommaso, please.
No.
I mean, we see... I haven't done enough to have a systematic idea, right, in terms of what we should expect, but we should expect some rise in the wedge pressure. We don't always consistently see that, I have to say.
Yeah, no, I agree. So there is a huge variability between patients due to the differences in the anatomy. The time it takes for the pressure to grow, it's about a minute. 45 seconds to a minute. And I have to say, I looked for a correlation between the change in microvascular resistance and change in the pressure across the balloon, and there was none, interestingly. I can't explain it.
But you're talking about 5 to 10 millimeters of mercury, not more than that?
No, sorry, I'm talking up to 30 sometimes.
Yeah. The wedge pressure. The wedge pressure can increase quite dramatically.
Okay.
Yeah.
Okay, I think we have to move on, and there's also a lot of questions in microcirculation on patients who have angina but have no ischemia, or but still have signs of angina based on microvascular disease. So I think we have our next speaker, Julien Jedge, is an expert on microcirculation, and so he's going to talk about this. Julien, please.
So we'll talk about the perspectives of coronary sinus reducer. It's just a plan and look at maybe the future, and I hope it will be that future. But we have seen a lot of perspectives due to this, and I will go back a bit on the mechanism. These are my conflict of interests. So coronary sinus pressure elevation, improve coronary blood flow. How is it possible? Is it counterintuitive? And I think in most of the organs, or when we think it over, if we have a road and the exit of the road is closed, and then the entry of the road is closed, and then it's the end. So how, when I close the sinus and I reduce the sinus, I might improve the absolute flow inside the organ. This is explained because a lot of organs are working like that, but the heart is spatial, and it is spatial in his venous systems. So in his venous system, you have multiple factors and multiple venous system. And if you close the highway, this study, and suddenly with the increase of pressure, you will open a lot of sideways going to the subendocardium. And what happening, it will influence the LVDP, and it would go through the Thebesian veins. So we have another road going through. So is it true? Is it really just a story I build, or is it effective? And I think Professor Banai, because he worked on this field since many, many years, and we need to recognize all his work, and that was tremendous work to show this, to show this Thebesian veins, to show this coronary sinus reducer effect, and to have, since waiting like 15 years to have a publication and to be recognized, because it was really, really difficult at that time to make understand that it is feasible and it is proved. So like a lot of new ideas and disruptive ideas, it's difficult to enter in the field, but he could open the gate here, and we need to thank him for that. So then I think Tommaso for his great work about just the simplest smart idea, and that was against sham. So you don't have any effect, and of the patient itself, of his impact, emotional impact. Let's say if you open a balloon and you close the coronary sinus with the balloon, you may face with a decrease of IMR, and this is important. This is important in the same way when you put a balloon in acute coronary syndrome, like the PICSO, and it was one of the best trial in 2018 in PCR, it was 5 years ago, showing that it reduced the myocardial infarction. We found the same mechanism with another tool, which is called absolute coronary flow by thermodilution assessment, and this one can monitor the flow, and we can have absolute values. We will not talk about index, but what we have seen in 10 patients, it's an increase of flow about 30%, and decrease of resistances about 20%, and the FFR remained the same in the coronary system. What it means, if I take again the image of the road, it's really when you block the main road, you would open a lot of side roads. And it will go to the subendocardium, but also the net effect, it's higher. So you will decrease the resistances and increase the blood flow. And I think that might be an explanation about the reduction of symptoms of angina. And since we are treating the microcirculation here, the FFI was not affected at all. It's not something about the epicardial artery disease. We are really treating the microvascular resistances. I'll show you the interim data based on patients without epicardial coronary artery disease, but with INOCA patient, this huge population that we are seeing every day, and we say it's a normal coronary angiogram. You have nothing. Go, and now we start to screen this patient for INOCA, and these patients, when they go through the coronary sinus, so 14 had a coronary sinus reduction in this work, which is in halfway. We see reduction of the IMR, improvement of the CFR, same class of FFR, decrease of CCS class, and increase of the 6 minutes working test. So I think it's really encouraging as a perspective. My conclusion is really simple. The coronary sinus reducer is a promising option to treat patients with chronic coronary syndrome, acute coronary syndrome, we have seen that, and INOCA. By its same mechanisms, but we have seen with multiple ways, and all the studies are going in the same way. It increases the absolute coronary blood flow, and it reduces the microvascular resistances. Thank you a lot.
Thank you, Julien. Thank you, Julien. So, do we have some question from the audience?
There is a question also. And maybe Thomas, if you would like to, or anybody else in the panel. What about migration of
I will see after the question if I take
what
it.
about the possibility of migration of the reducer, and maybe related to that also is what would be the best position to implant the reducer? How close to the ostium can you actually go?
Yeah, so my advice maybe for people in the room who will start their program in the coming weeks, indeed will be to be probably far enough from the ostium to be sure that we have a significant oversize as we discussed, because it will then completely fix probably the device in the wall of the coronary sinus. And the third one, as we've seen nicely on the smart screen, will be to be very careful when we remove the balloon for the last step, because sometimes you put the device, you're very happy, everybody will start to congratulate, and then we forget the last step, which is probably the higher risk of embolization. So position distal to the ostium, oversize, and be very careful with the last maneuver of balloon retrieval.
And Stefan, is there a learning curve for this implantation? How many sinus reducer we need to implant before we are?
I think it depends of the experience that, of course, you have with the coronary sinus. As interventional cardiologists, we're not really trained in the coronary sinus, except for the EP people. But I think it's really not that difficult. I think you need to be able to do, and there's always a proctor. If you start, there's always a proctor around who will guide you and take you to the first 2 to 3 cases. And if that goes well, which it usually does, then I think you're good to go on your own. It's not, unless I guess everybody agrees with that.
I would strongly recommend to get proctored by Shmuel Banai. I think that should be a requirement for starting a program.
Okay, there you go.
Proctored by Shmuel Banai.
I had Stefan, it was very good as well.
I think Shmulik has nothing to do anyway, so he's available.
So unfortunately, we have to close this session with a very interesting session. So the key message for our part is that this angina, refractory angina, is not so rare, and you have to look to it. And this sinus reducer increase pressure in the coronary sinus, which way we relieve the angina. And you have so that there is a randomized sham control trial who prove the efficacy of this new device in this treatment. The procedure, as Thomas showed us, is simple. However, and it's very important, it's to respect different steps in order to have a success. And as Julien showed us, there is some perspective. So it's not only a refractory angina due to coronary artery disease obstruction, but also for acute coronary syndrome and also INOCA situation. So thank you so much for your interaction, and thank you for all the experts for this. And it's very important, if you want to have more details about, there is a training village organized by our sponsor, which is Shockwave, and you can have all the questions that we cannot answer because we have not a lot of time. Thank you so much.